I'm currently in my gastroenterology training specialty. Um, and I'm here to kind of talk to you a little bit about why I chose GI and why I think you should also think about maybe the specialty. And it's a really exciting specialty. Some of the things that I also didn't really know in medical school became apparent over time. And I really wish I had some sort of resource or platform where I was told about some of the opportunities if I chose this specialty. So I'm here today to kind of like answer some questions. I know a lot of people have like questions, especially in GI and what we do and how we do it. So here we go. Okay. So a little bit about me, as I mentioned, I'm a second year GI fellow. So how did I really get here? So I did 3 years of undergrad. I saved a year because I did like AP credits and honors credits, and I somehow accumulated a year. But I took a gap year, and then in that gap year, I became an EMT, and I like focused on things that I really enjoyed, like traveling. I worked for a restaurant, so I did a bunch of things that actually ended up um, uh, making my interviewers who interviewed me for medical school very interested in my application. I did 4 years of medical school and then 3 years of internal medicine residency after that. So you get your MD or your DO after medical school. And then after your internal medicine residency, you have the choice of either becoming a hospitalist or doing primary care, working as an attending, or if you wanted to specialize. So like some of the specialties are cardiology, gastroenterology, rheumatology, infectious disease, and hematology, oncology. Those are the common ones, but that's an extra set of years of training, and most of these training programs are anywhere from 2 to 3 years. And if you are interested in a particular niche of your specialty, there are fellowships, like super fellowships like that. So anyway, so total 13 years of school. And then in GI specifically, there are, as I mentioned, there are 4 like subspecialty fellowships. So inflammatory bowel disease. So you're taking care of patients with like Crohn's disease and ulcerative colitis. So I'm sure you guys have heard some of these like diseases before. But you can be a specialist in that, but you need to be a gastroenterologist before you become a specialist in something like that. Therapeutic or advanced and gastroenterology. So that's something that I'm planning to do. It's a little bit more involved, a little bit, you learn more skill sets, more tools. So we'll talk about some of the really exciting toys that we have in GI. Transplant hepatology. So you're dealing with a lot of patients who are post-transplant, post-liver transplant, and you're managing them and you're monitoring them. Also, as a hepatologist, you can prevent patients from developing cirrhosis, manage patients with cirrhosis or liver diseases, which have an array of causes or potential causes. And then motility. So motility, things like if you've heard of conditions like gastroparesis or achalasia, these are commonly encountered in the motility specialist office. So, and even GERD, like, refractory GERD, stuff like that. So, the nice thing about GI is that we have all these like different of the specialties, and but if you decide not to even do any of those subspecialties, you still get exposure to all these types of patients in your general GI practice. So I think it's a win-win. Let me just go to the next slide. Okay, so where I studied and trained, I get a lot of questions about this. And I've posted about this on my social media several times, but really a lot of the questions I get is like, do you need to train at like, an Ivy League, or do you really need to move away from like your hometown? And really what was important to me where I studied and trained, and the places I applied to, and the places I ranked. Location was a big thing for me. So staying in New York was very important to me because my family's here, and my loved ones are here. So I went to a CUNY in the city, Hunter College. It was a commuter school, a bunch of students every class, and then I did 3 years there. And then I went to SUNY Downstate, that's in Brooklyn, really serving an underserved population, Haitian Creole, French Creole speaking patients, underserved immigrant communities, resource poor. So SUNY Downstate was my medical school. And then I went to Montefiore for my internal medicine residency. That's in the Bronx. Again, an underserved population, high need. And I spent 3 years there. And that's where I really fell in love with GI as a specialty. Because when I first started as a internal medicine resident, I wasn't sure if what I wanted to do after residency, if anything. So I fell in love with GI there, made all my connections, did my research. So I'll talk a little bit about that later. And then now currently I'm at Stony Brook, which is in Long Island. So I've been kind of all around New York. Most of where I studied and trained is in the city. So now I'm kind of enjoying the suburban life, and driving everywhere, but it's really, really exciting. And I love the extra parking. So, all right, so people always ask me why gastroenterology. So I kind of broke this down into like the 5 Ps. So the pathology, pathophysiology, procedures, people, progress, and professional growth and satisfaction. So I'll go through each one of these reasons why I chose gastroenterology. And in hindsight, these are kind of like the reasons I found. But when I was first applying, I really only appreciated like 2 or 3 of these reasons. And now kind of like as I'm training and as I'm seeing like the field advance and like the people around me, I'm like, wow, like this is the perfect field for someone of my my personality type. So the pathology, pathophysiology, I'm going to start from the basics because I don't really know where everyone is in terms of like familiarity with the topic. But so the organs that we typically deal with are the esophagus, the stomach, the small bowel, the colon, the liver, the pancreas, and the biliary system. So if you can take a look on the first image on the left, so the entire GI tract, it starts obviously with the mouth. And then we deal with disorders of the esophagus, the stomach, and then it goes into the small intestine that's divided into 3 portions. There's the duodenum, there's the jejunum, and then there's the ileum, and it's a very long, hollow tube that carries many functions, including digestion. So, and then it connects to the large intestine. From the ileocecal valve, if you've heard that term before, that's the connection between the small intestine and the large intestine. It's a valve, it opens and closes, and it really controls the passage of contents from the small intestine to the large intestine. So then food goes into the large intestine, and water gets absorbed, and then you start forming stool, and the color of the stool is more apparent. It's like this classic brown. So really we deal, and even the end of the large intestine, of the rectum and the anus, where you can treat hemorrhoids and stuff like that. So that we do deal with basically disorders of this entire plumbing system, but also we also deal with the organ, the liver and the pancreas, and basically the biliary system that connects the entire so what we do in gastroenterology, so we basically treat structural, functional, and behavioral causes of pathology of the GI tract. So certain structural pathology that we deal with are masses, we see polyps, we see growths, cancer. So what can we do with um, when we, with pathologies like this? We can biopsy them, we can remove them, we can really try to help make the patient feel better. And all of this, I'll show you in the next few slides how this actually looks. But we do all of this endoscopically. Like, we don't cut the abdomen. We don't, the patient's mainly in moderate sedation. They're breathing on their own. So we could really do a lot of this stuff with low complication. It's a pretty, like, these are very low, like more or less low risk procedures. We can treat inflammation like gastroesophageal reflux disease. We can treat peptic ulcer disease. We can treat perforations in certain cases. Holes get created somehow in the GI tract. We can patch those up with some of our more advanced tools. We can treat food impactions, which can be pretty high complication after a certain time if the food or whatever gets stuck in the esophagus. Is stuck there can cause a hole. So that's an emergent procedure for us, and that's something that we can quickly treat, and the patient feels better, and we can just discharge him that day. We treat gastrointestinal bleeding, so bleeding from the upper GI tract, bleeding from the lower GI tract, even bleeding from the small bowel with some of our more like advanced tools, which I can talk about later too. We can treat, so as I mentioned, we do deal with pathology in the liver and the pancreas and the biliary system. So part of our more advanced procedures, we can remove stones from bile ducts that are causing like sepsis. We can put stents in like the biliary tree or in the pancreatic duct to relieve obstructions, to treat like masses or cysts, or there's so much that we can do endoscopically, and it's something that I even now every day when I go into work and I see some of these procedures, I'm like, wow, like I can't believe we can do this, and like the patient just like wakes up and they're fine. We treat functional pathologies, so swallowing disorders. So as I mentioned, like achalasia, gastroparesis, so delayed emptying of the stomach. We treat that through different therapies. We can inject Botox. We can do these things called myotomies. That's something that surgeons typically used to do or still kind of do, but we can do it endoscopically, and the same outcomes and low rate of complications. We treat constipation, diarrhea through medications, through certain recommendations, through diet. So a lot of what we do in GI is not just like, it's really cool to do all the procedures, but like you also have the gratifying aspect of treating like long-term conditions and long-term diseases and see how they evolve over time. And it's not that you're just dealing with the GI tract, you're dealing with the cardiovascular system, how the blood supply is affecting what you're seeing, or the nervous system, or I think GI, since all the organs that we deal with span the entire body, we're dealing with all these different other systems of the body that I feel like I wasn't getting that sort of comprehensive exposure in other subspecialties, despite the fact that like there were procedures, and I'm a procedure junkie. But really, I think if you like having that internal medicine exposure throughout your career, and like really knowing the medicine while learning something really cool and procedural, I think GI is one of those specialties you should really consider. All right. So also what we do, we prevent cancer. So in the esophagus, we can treat conditions like Barrett's esophagus. Oh, sorry about that. We can treat Barrett's esophagus, which is a precancerous lesion. We do like radiofrequency ablation, so we can basically ablate dysplasia or Sorry. And then in the stomach, we treat H. pylori, which is an infection that can cause a certain type of cancer. We can treat ulcer diseases. We can remove polyps in the stomach. In the colon, we also remove polyps, and that helps to prevent colon cancer. And we even treat conditions with the liver. So, like if you're even a general gastroenterologist and you're interested in liver stuff, you can manage patients with cirrhosis, which is like scarring down the liver and managing those complications, or preventing cirrhosis. So like, telling them to lose weight if fatty liver is the cause of their cirrhosis, or having them or treating their hepatitis C, which is another cause of cirrhosis, or asking, helping them stop drinking alcohol, because alcohol also can cause a prolonged heavy alcohol use can cause cirrhosis. So, and then pancreas. So like usually if you see like cysts, or if you see like growths or masses and stuff like that. So there's like, you do a lot in GI, and I think their patient population can be pretty varied, but still like very exciting. So how do we do all of what I just told you? You're probably wondering like, oh my God, there's like, you just gave me all this information about all the things that you can do, but really like, how do you do it? So I mentioned we do this all through like what we call an endoscope. An endoscope really just means like a tube that has a light and camera at the end, and it's going into like, your esophagus or your stomach or your colon. And we have different types of endoscopes. We have one that goes from above. We have one that goes through the colon. And we have other special ones that have like ultrasound probes on it. I'll show you a picture of it later. And then we have one that like can really help us get into the biliary tree and do all like what we do, like put in stents and like, anyway. So essentially this is the view that you get. You see a monitor, you're using the endoscope in your hand, and you're using both of your hands to kind of, do maneuvers. So if you, I don't have a picture of it, but at the end of the endoscope, which is what you see like in the duodenum, at the end of it, if you face it forward towards yourself, you'll see a few components that help us do what we do. So you see a camera, you see a port where we can thread instruments through. So like clips, cautery, banding. And then you have, and that port also is a suction port, so you can suck up whatever fluid or blood or whatever you need to do. And then so those are really like the main components of like the endoscope. These dials that you see is how we control it. So you use the dials to kind of maneuver the scope, and you can even maneuver the scope with your right hand. So if some of you have played video games, this is not that dissimilar to like playing a video game where you really need a lot of hand-eye coordination. So endoscopy can be done in the hospital setting in what we call an ambulatory surgery unit. It's not done in the OR. So for those of you that don't like the cold of the OR, or GI is generally not sterile, but you try to be as like clean as possible, but it's not like a requirement. Like your patient will sustain an infection if you're like not sterile. We can do this in like a clinic setting. So we could do our endoscopes in the clinic setting. So it really depends like where, what kind of environment you kind of want to work in. For me, I kind of liked being out of the OR, but still being able to do procedures. And sometimes you could do procedures all day and like have that, schedule worked into your daily life in your week. So basically what we do now in the era of COVID, we're wearing a lot more PPE, like masks and goggles and shoe covers and N95s. But really, you have your patient, they're laying on the bed. You could see they're generally not intubated. You do require anesthesia, so you do have an anesthesiologist or at least a CRNA, delivering propofol or some sort of anesthetic. Um, and you're looking at a monitor, and you're basically, this is how you're doing it. It's like playing a video game. So what are some of the toys that we have? So as I mentioned, there are these other types of endoscopes that have different features and different capabilities depending on like what you're trying to accomplish. So just like if any of you have seen like an ultrasound probe and like, either on a pregnant belly or like on the heart or like on the belly itself, and like a lung exam, you can see like it's an ultrasound, and you're using like gel and jelly to kind of see the structures underneath. That's something that we can even do in gastroenterology. We have a specific scope, endoscope called the endoscopic ultrasound scope, and it really, we can see like cysts and structures underneath. Like we can see the layers of like the stomach and like the small bowel, and like really decide like if this is something that's amenable to therapy, and if we can help out without the patient having to undergo such invasive surgery. So this is a typical image of what you could see on an endoscopic ultrasound. So you can see the esophagus. You can, certain parts of the esophagus, obviously, like they're in very common structures that you can recognize, like the aorta, and like if you're looking at masses, so like you can see like you can that area on the right side of the screen doesn't belong there. It's a mass. So sometimes we can even be or like even get biopsies endoscopically. So in the endoscopic ultrasound, there is a port that you can snake your instrument through and get biopsies of this mass. And if say it's a cyst, you can drain the cyst. So all of this is like stuff that we have doing in the last like 2 decades, and like I mean more and more in the last 2 decades, and like I think a lot of the tools that we have are more refined, and there's a lot of innovative uh, feature in GI. So these are some of the tools that we can snake in through our channel that I mentioned earlier. So on the upper left, that is a biopsy. So you can take biopsies of like concerning lesions or polyps, or you can biopsy for H. pylori. If you see inflammation, you could biopsy the area, just make sure there's no cancer, no infection. On the upper right hand corner, that's something called a snare. And a snare, this can be hooked up to like cautery, or like a cutting cautery, or it could be done cold. So if you see a polyp that you want to remove in the colon or in the stomach, you can just like snare this thing around it and like take it off. On the lower left is our injector needle. So we can inject a bunch of things. We can inject epinephrine to slow gastrointestinal bleed. We can inject Botox to the pylorus to help improve symptoms of gastroparesis. We can inject kind of like saline or lifting agents to lift up our lesions so we can see them better. So when we cut, it's like safer to remove them. We can even tattoo things with that. Say like you see like a colon mass or colon cancer, and either you like want to remove it or it's too big for you to remove. So you either send them to an advanced gastroenterologist to see if they can do some more advanced removal, or a surgeon, you can tattoo that area so someone knows where they're going. And say that patient needs an actual surgery where like that portion of the bowel is removed, you can see the tattoo from the other side. So it's very helpful for us, and it's also helpful for other specialties who are taking care of your patient. On the lower left is a balloon. That balloon we can use to dilate strictures, really mainly to dilate strictures of like any cause, malignant strictures, benign strictures, post-surgical strictures. Say like someone had like a bypass or something and they have like too tight of a GE junction, you could use this device to help like loosen things up over time. In EOE, also eosinophilic esophagitis, we could use this. So that's, and one thing I didn't show you guys is something, is our stents. Like, so stents are essentially, they look like those little, I don't know if you guys, if I'm too old and maybe I'm showing my age, but like, if you put those like little, like those little toys, I guess, you put like your two fingers and like you stretch it apart and like it's like this like braided overlay of like pattern, so like that, and it kind of gets stuck on your both your fingers, like if the stent looks like that. So I don't know if I'm giving any sort of like visual representation of what it looks like, but anyway, so stents, we can put stents basically anywhere. We could put stents in the esophagus to help treat holes, to help improve someone's swallowing. We can put stents in the pylorus, between the pylorus in the duodenum, to help like open up, say like malignant strictures, say someone can't eat, or like they like because of their cancer, the area is like all you know, full of cancer tissue, so we could put stents in there. We could put stents in the biliary tree, like I mentioned, to open up strictures, to ease the passage of any stones from the gallbladder. In the pancreatic ducts, we could put stents. We could put stents in the colon too. So anyway, enough about stents. But one thing I do want to say is that we do have this system called the lumen opposing metal stent system, where we can actually create like a hole between two like GI organs, to, or like between a GI organ and like a cyst, or like to actually drain like cysts, or like to provide some sort of therapy, and they're called Axios. That's like the company name, but they're called lumen opposing metal stents, and that's something that we can do endoscopically and remove endoscopically. So this is something I was kind of mentioning. It's this is really like the biliary tree. I keep alluding to the biliary tree, but really on the left, you see the gallbladder, you see gallstones, and like those gallstones can get stuck in the cystic duct or the common bile duct and wreak havoc, especially if they get stuck there. They cause infection, they cause sepsis. People can die from this. So it's an emergency, urgent procedure for us to take care of, especially if the obstruction is not being relieved otherwise. So on the right, you see something called a duodenoscope, or basically this is a scope that we use to perform ERCPs. And you guys have probably heard of ERCPs, but basically this is like another way for us to like access a structure, the GI tract, that we normally otherwise wouldn't have. But previously in the past, these patients who've had stones stuck in their bile ducts, they would have like and it does still happen in certain cases, especially for high risk cases, but they have like, you know, surgeons or interventional radiologists will put like a tube externally from the outside to try to relieve the blockage. But this is something that we can do endoscopically. It takes about an hour, hour and a half, sometimes even less. And we can take a balloon and like sweep out the stones. So, and this is the same device that we can put in a stent in the biliary tree to help ease more passage of stones. Pretty cool, huh? Anyway, so this is one of the P's, procedures. So I wanted to show you guys something really cool that actually got me really interested. But okay, so just try to share my screen. Wait.
don't see it yet. Okay, there it goes.
Okay. Yeah, okay. All right, so this is one of the videos. Really no one's saying anything, so I'll kind of narrate as we go along. But this is really like, say, like one of the GI bleeding cases that you could be familiar with if you're a GI fellow. But really, this is the stomach. We're in the stomach. This is the pylorus, so it's the area where it's cinched into the edges into the duodenum. So you see fresh blood here. This is not normal. This is not normal mucosa. This is all blood. It's fresh blood. So I'm just gonna skip through a little bit parts of the video, but your job, so say like someone's coming in, their hemoglobin is dropping, and like you have no no clue why, but they're having black stool or they're vomiting fresh blood, and they're very unstable, their blood pressures are low, their heart rate's up, and like you're pretty sure they're having some sort of active GI bleed from above. So you use the endoscope, like I mentioned, and you essentially go in through the esophagus and you go in and try to see if you can treat a bleed. So as I mentioned also earlier, like you have these different tools underneath your belt. So what you're seeing here right now is one of the tools that we're snaking in through. There's an injector needle at the end, and essentially this gastroenterologist is injecting epinephrine in the area that they think is the culprit of the lesion. So they're injecting epinephrine to kind of constrict the blood vessels to reduce the blood flow so the visibility is a little bit better. And then I'm just gonna skip through certain parts. So they're still injecting. There's still some injection. Okay, that's so like the field is a little bit more clear. This is in the like around the pylorus of the stomach where this bleed looks like it's coming from. And just a lot of fresh blood. So you essentially suction all of this while you're doing the procedure. Obviously, it can get a little stressful, you know, especially if like your patient's still losing blood, but everything's in controlled environment, like you're giving them blood while this is happening. All right, so I get to the part where they treat the bleed. There's a lot of, okay, so this is one of the, like a device that we use. It's a hemostatic clip. We can clip the area where we think is bleeding. And really the things that can bleed are ulcers, doulofoil lesions, which are these like arterial like projections that bleed every so often and have no reason why they bleed, but they do. Masses can bleed. So this is a hemostatic clip. So the first clip is being placed, and I think they put yeah, there you go. They put a second clip here. So you can really like put these clips in endoscopically, and then what they end up doing at the end, which I think is really cool, it's like one of the newer therapies that we have for treatment of bleeds, is especially if you feel like you haven't 100% like treated the bleed, or you think that there's a high risk of rebleeding. You can do something called, okay, so this is an end product of what the clips look like right there. So what they do is something called hemospray, and it's like this spray, it's like this powdery spray that you can spray on the area that you think still has a potential of rebleeding, or might still have some residual bleed. I mean, this might be a little overkill, but sometimes like this is something that we can do. All right, so that's the first one. And then I'm going to show you guys like another, okay, so this one I wanted to show you. All right, so let me share my screen again.
All right, so we begin our discussion here with tissues.
Sorry about that. Can you guys see this picture?
Yes.
Okay. All right. So this is something, so just a little premise to this. So like sometimes patients with cirrhosis, they can develop such a backflow of essentially the portal system that there are these like vessels that form around the lower part of the esophagus, and they can engorge, especially with over time if the liver gets more sick or more scarred down. It's like a highway system, so the blood can't drain through the liver, so there are these collaterals that develop to try to drain the blood. And if the liver keeps getting sick or more scarred down, then those highways get more and more available for the blood to go through. So essentially, there are these veins that develop at the end of the esophagus and they engorge. And this is not normal. This is not normal anatomy, but it happens in patients with cirrhosis. And these veins can pop and they can cause fatal bleeds. Like, hands down, if your patient is having a variceal bleed, that is like most often fatal. And really, our job as gastroenterologists, this is something that I would come in the middle of the night to scope. And not very common, but it does happen. But essentially, your job is to stop that bleed. So this is a video demonstrating just that. So as you're seeing, there's a lot of fresh blood. This is one of the varices. You see like that projectile like blood in the bottom of the esophagus. It looked like it was an active bleed, right? Because it's like bleeding, so you see it's active. So this is a very scary situation for a lot of us. I'm sure a bunch of us get palpitations while we're watching this. But essentially what the goal is to try to stop that bleed. So you guys are probably wondering, like, how are we going to stop this bleed? So we do something called banding. So I think they do clips here, but we can do something called banding. And I'm just kind of skipping through the video to see if they do that. But there are these rubber bands that we can essentially band at the end of the esophagus, and they basically decompress the entire vein that like feeds the area that's bleeding, and the patient stops bleeding. So I want to show a gratifying picture of this. So all these, like, you see these like engorged vessels, like this is not normal anatomy. This is someone who's developed varices due to their cirrhosis, so really bad portal hypertension. And so anyway, so the bleeding was stopped and we basically put bands on stuff like this. So this is something that we can do. All right. I'm going back to my PowerPoint. Sorry, I know this is like me going back.
Hi, my name is Ala Shurara. In this short video, I will review with you the endoscopic management of gastric varices, namely the endoscopic obliteration.
Sorry about that. Okay. All right, let's share screen again. Back to the PowerPoint. Okay, so really, like, the procedural part is really exciting. It's adrenaline inducing. And if you're a procedure junkie, this is like totally the field for you. All right, one of the 5 P's is people. I think my personality really meshed well with the people in GI. We don't really take ourselves too seriously. We really like poop jokes, and we're really friendly and easy to get along. One of the things, like, I felt like when I was rotating through in medical school was that, like, I felt like my personality just gelled more with the people in GI and not in surgery. So here are some pictures of me and my co-fellows. We're essentially like a family. We rely on each other. We're always like, our call schedule can get pretty brutal, especially as a first year fellow. So having like these guys like kind of helping you stay sane throughout the way is like really nice. But yes, we eat donuts. We deserve it because we're always on call. Just kidding. This is like really a bunch of my co-fellows from last year. And this is when we're on service. We get medical students and residents rotating through the service, and this is really, really fun. Our attending actually is the one in the front with the glasses, Dr. Patel. So everyone who rotates through the service really, really enjoys it because I think the people and like the willingness for us to have like people watch procedures, and I think everyone's just like super nice and super approachable, and there's lots of opportunity. This was last Halloween in 2019, pre-COVID, but these are all my co-fellows. So I get another question I get a lot is like, what are the steps to get into gastroenterology? So really, you need to have a passion and or interest for it. It's a long road in medicine. So I definitely don't go into something because you think it's going to be very lucrative, which, you know, GI, like it's kind of like in the middle ground of like what you could really make it as lucrative as you want it to be. But that being said, you also need to reach out to mentors in the field. So like what I did is I reached out to fellows, I reached out to GI attendings who could really like help me get to the next step. I seeked out definitely shadowing opportunities, and I'm even doing this now where I'm like interested in like advanced endoscopy and endobariatric. So I'm like I'm like shadowing, or I'm like, you know, asking if I can, you know, see procedures or do them or help out, whatever. Research is really important, especially for GI. GI is typically a pretty competitive field. And this is something I kind of tell people early on if they're thinking about it, is to have some sort of primary research. Case reports are nice, definitely show interest in like the societies like ACG and DDW. Get like, even if it's a case report, just have something like presented just to show that you're involved. Network. I think really once you pass the stage of matching into residency and you're looking into like specialties or like fellowships, it's really about networking as well. People getting to know your name, seeing your face. Like if you like shadowed, like say like a very prominent GI doctor in like this particular niche, like, and say like you apply to their fellowship, like I get like a letter of recommendation from them, or at least like they can put in a good word for you. So like networking is actually a big part also of getting into GI, or at least like, you know, being more marketable for GI. Prepare ahead of time, checklists. I use a lot of checklists, or like at least mental checklists. Like what are the deadlines for things, like definitely keeping a timeline. There's a lot of stuff going on, especially with like, you know, now COVID again as a second wave. But like despite that, like you know, research and networking, all of the things, like it's really hard to keep track, especially if you're also trying to learn internal medicine. So there's a lot that goes behind the scenes, but just taking it day by day, keeping your checklists were something that helped me. Self-care. So I know all of us have the tendency to like just sit there and like be like, okay, I need to like bust my butt for like through like for the next like 10 years. But yes, you are working hard and you are like dedicating the time and sacrificing. But like one of the things I think was like my saving grace and kept me sane was like staying in touch with my family, hanging out with my friends, like doing the things that I liked. I went to the gym, I still dance, like stuff like that. Obviously, like, you know, certain times, certain things take priority, but like just don't stray away from something like that because it helps you like grow as a person. And then something I say like for people that like are just pursuing medicine in general is to be like a good person, and don't be like, you know, like someone who just like isn't interested in helping people, or like, you know, being reliable or diligent. Like I always implore people to try to emulate the person that you would want to be your doctor, or like the doctor of your loved ones. Like if, say, God forbid, your loved one was going through something, like you should be that doctor that like you would want to take care of like your loved one. So all of the qualities of like a good physician, like kindness, compassion, shared decision making, be diligent, be prompt, always show up. Like it's it's okay to not know things. And like, I feel like even now, I'm like, the learning curves are always going to be steep. No matter what you do in your life or where you're going, especially in medicine, because it's not just like the medical knowledge, but it's like how to work in a team or how to do your day-to-day work and how to like logistical stuff. Like there's a lot of learning, especially even for like procedural specialties. You're learning like a new skill, you're learning the tools, you're learning the possibilities. So that takes time, and be trustworthy. If you don't know something, say you don't know. That's okay. Like I think like looking back, or even like looking at residents and like medical students, like the people that I'm like, oh, I give a really actually a pretty good evaluation to, are people who are like honest with me, and people who are like, okay, look, I don't know this, but I'm willing to look it up, or I'm willing to like, you know, I can look it up, or like I know where to look it up, or, you know, or is willing to just like engage in some sort of like educated discussion, or like, you know, I don't know, show interest. Like if you're rotating through the GI service, like show your interest, like show that you're engaged. Because like the worst thing I think for us is like having someone on the service who's like not interested at all. Because you're wasting your time and you're wasting ours, frankly. So and then one of the other P's in GI are the progress or advances in GI. So you can do bariatric treatments, so like endoscopic suturing, and treat obesity, balloons. You can drain cysts, like I mentioned before, like the lumen opposing metal stents. You can do like these larger dissections of like tumors. And you can relieve gastric outlet obstruction through one of those stents, etc. So progress professional growth is also one of the P's. So this is me when I first started my social media journey, like 7 months ago. And this is me presenting a paper at one of the conferences that I mentioned. So again, like I'm definitely like telling you things that I've done, and I'm here and I know like what worked and what didn't work. So these are the things that work. So definitely some research, some primary research, especially. This is a picture that I took, actually I was in Canada, but this is one of my professional pictures for like an op-ed that submitted during the pandemic, and like it was like featured all over like Stony Brook, and that was really nice. Like I think people started to like know my name a little bit more and like know what I did and who I was. That was really fun. This is a picture of me in the OR during the pandemic, and we were scoping a patient in the COVID era. So this is all my PPE. I don't use all of this PPE, but I use, I think, most of it, except for like those long booties. But you know, sometimes in certain cases, I definitely look like this, so you don't even know who was behind all that PPE. You really take advantage of like it. You really start to appreciate like all the things that you took advantage of like before the pandemic. So, and this is me right now in fellowship. This is a picture I took like the, you know, on picture day, my few weeks into year of fellowship, and definitely not looking back. I'm excited. I'm second year, and I'm finishing my third year after next year, and then hopefully an advanced fellow. So anyway, lifestyle and career. So really, it's what you make of it. I get this question a lot. So in GI, you have the benefit of really making what you want of your career. If you want to work in an academic setting versus private, you could do a little bit of hybrid between the two. If you want to work with a large hospital system versus community, you have inpatient and outpatient exposure in this long-term care. So you really get to develop a relationship with your patients. And then really like your priority. So as I mentioned in the beginning of my talk, family, location. Also my priorities was seeing like the pathology I wanted to see in the patient population. Like I wanted diversity. I wanted a varied patient population. So I saw all kinds of things and like resources. So like what are the resources that your institution has? Like if you're interested in say like I don't know, like a subspecialty in GI, like inflammatory bowel disease, definitely look for an institution that like has attendings that are IBD specialists or like have like connections with like those types of resources so you can get that exposure. Compensation, I think I just put this number out there, but I think it's a lot more than this. Um, I don't really have a full sense of like the overall compensation, but I think it's because there is such a variety of like the settings you can work in and like how you're compensated based on that. So like the talk tomorrow actually with Dr. Rao, she's a gastroenterology attending. She might be able to help you guys out with that question. Anyway, so thank you so much. This is the end of my talk. I like these cartoons from Awkward Yeti, and I think they're hilarious for things in GI. But if you guys have any questions along the way, I'm on social media, and I'm on Instagram and Twitter. I'm ready. You can DM me, reach out to me, any questions that you feel like you wanted to ask me personally, or you felt like weren't answered during the session.
Thank you so much, Dr. Advani. This was an amazing presentation. I think if you open up the chat right now, you can just see all the thank yous and kind words. Everyone loved the videos. Those were a really great touch.
Oh, yay. Thank you.
So I guess like we'll spend maybe just 5 minutes real quick answering questions. And like Dr. Advani said, you guys can always message her if you have any other questions that we don't get to today. I think some of the more common questions that we got during the video was what happens to the clips and the bands? Do they stay in the body? Do they dissolve? Do you have to take them out? If you kind of talk on that.
Yeah, so actually a lot of the therapies that we deliver are meant to kind of like dissolve or like pass on their own. So like clips, they fall off on their own. There's really no timeline, but usually they fall off like within like a week. But I won't lie, I have seen like clips like a year later, but really like it does nothing. It just kind of like hangs out there and it's like all like, you know, attached to tissue, but there's I've seen that, but the bands fall off usually within like 3 or 4 days. And then like sometimes you can get ulcers after placing a band, but usually all of these like treatments are things that we don't have to go back in and like remove or anything. Sometimes people can rebleed and we just go in and we try to see. Really, like the thing about GI is like you have all the tools and you have all those skills underneath your belt and you know what each one does. So like you only know what you see like when you go in. Like you can't predict what you're gonna see. And that's the beauty about being in like a procedural specialty. Like even if you're a surgeon, you don't know what the abdomen is gonna look like. You don't know what you're gonna see. But if you have all the tools, if you have all the skills, like you know how to use them, then you could really tackle anything.
Great, thank you so much for answering that question. There was a couple of questions. So in those pictures that you showed, it was only you and 2 other females. And so could you give some insight into females and GI and just where you see that the numbers going?
Definitely. That's such a good question. Thank you for asking that question because I feel like a lot of my crusade on social media has been like, you know, female empowerment, like women in procedural specialties. And I'm a firm believer in like women like kind of like dispelling this myth that like the lifestyle in GI is like very surgical and like you don't have a lifestyle, like you can't have a family, which is like actually so far from the truth. Like my co-fellows have had kids in fellowship, like they have like these very like fulfilling lives, my like female GI attending. So going to your question about like how many women are actually in our specialty, so I think it's still a pretty male dominated specialty, and I think that has to do with a lot of the procedural like fields off of medicine now that we're getting more women like in medical school and like into these procedural specialties. I think the curve is going to shift and it's going to be more balanced. But that being said, like I think like as a female physician resident, like I was always told like, oh, like why do you want to do GI? Like you won't have a life, or like you won't like be able to like see your family. And I'm like, So then I started speaking to like female gastroenterologists, and I was like, is this true? Like, are you guys able to like have families or like, you know, be around your loved ones or really have fulfilling lives? And they were just like, yeah, like totally. Like you can, again, like you can really make what you want out of the field and specialty, and you can kind of just like take it from there. But I definitely think, you know, with a bunch of us female GI physicians on social media, like I think our goal is also to like inspire like future young females to like pursue the specialty, because A, it's freaking cool, and like B, you have a really nice lifestyle if you want it.
Great. Thank you so much. I think that was really kind of put into perspective for a lot of people. So thank you for your advice on that. I guess just the last question before we wrap up, could you give some insight into DOs versus MDs in GI? Is it harder as a DO to get into GI? Is it seen as a competitive field? Do you have many DO colleagues? If you could kind of give some insight and talk about that.
So yeah, I mean, the thing is that the answer to your question is that yes, it's a competitive specialty, and I think even as an MD, it's difficult to get into a specialty like this. But that being said, definitely in the last like 5 years, I've seen a lot of my DO colleagues also get into GI fellowships. So like I mentioned earlier, I think if you have like the right mix of like networking, research, like you have like good connections, like people speak favorably about you. Like I think whether you're a DO and MD, like you can even come. I have had colleagues who've come from like Ivy League institutions and have not matched because they just don't. They haven't done the research, they haven't done the networking, and they think like the name is going to carry them, and it doesn't. Like GI is one of those specialties that like you really gotta like show your interest. So whether you're an MD, whether you're a DO, whether you're male, whether you're female, although I think a lot of programs like are favoring like, you know, trying to engage more women physicians to enter the field. So I think, you know, there's like this push, but like regardless, I think you just got to do the work.
Great. Thank you for that advice. A lot of people were very inspired and said that you're really eye-opening. So thank you for your numbers or your just your trends that you see. So the last question that I have for you before we end is, what advice would you leave us pre-med students with, especially now with a second or maybe even third wave of COVID hitting?
Ooh, a piece of advice or like concluding remarks kind of thing.
Yeah.
Well, I would say one of the things that was very important, and I think is still very important, is to like show up. And I know it's like such a like you're like, duh, of course I'm gonna show up. Like someone's evaluating me, but that's not even just that. It's like, yes, your evaluation aside, I think if you show up and if you show interest in whatever field of medicine, whatever area of life you want to go into, and people see that interest, opportunities will come to you. Like, yeah, you definitely have to take those steps to seek out opportunities, but like in my situations, if I see like a resident or a medical student, like they're really excited about GI, they really want to learn, I'm more willing to be like, hey, like, you know, let's talk about this like disease path. Oh, come to endoscopy and see me scope or see some of the attending scope. Like if I see people, if you're interested, then those opportunities will start coming to you. That's actually like what ended up happening to me. Like I was just a dork and I did like totally got excited about all this stuff, and like people were just like, oh, like why don't you do this research project with me, or why don't you work with this fellow, and like, you know, whatever. There's like so many opportunities to collaborate. So that's I think one like life advice and one like career advice I can give.
Yes, thank you so much. I do think that's really important. Just show interest. Let people know you wanna be there and join in.
Yeah.
Well, thank you so much for joining us this evening. We really appreciate all of your advice, all of the just educational things that we learned. Those videos were amazing.
I'm excited.
And then, like we said, I'll put your Instagram handle in the chat again real quick. And then if anyone has any more questions for Dr. Advani that we couldn't get to, go give her a follow, DM her, ask her some questions. And thank you so much. This was awesome.
Awesome. Thank you so much for like arranging this. I really think you guys like are ahead of the curve by even doing something like this and like taking the reins in your education and your career. So hats off to you. Thank you again. Best of luck. And feel free to DM me and reach out to me if you have any questions, okay?
Great. Thank you. Have a great night.